Thank you very much, Dave. You may be seated. Thank you for mentioning Ukraine, Dave. It's been heavy on my heart the last several days, and I couldn't help but remember Carl Stauffer's conversation and think about what he might be doing to get involved with peace in the Ukraine. So thank you very much for mentioning the situation there. I don't have a hospitality committee person here today, so if you have any guests that you would like to introduce to the rest of the club, please do so. We received Noah Yoder's application for membership the other day. So Noah, if you want to stand up and just raise your hand. So we'll have that in the rotograph next week, I believe, and hopefully a induction ceremony in the coming week. So Noah, thank you very much for being here. And Shannon, thank you very much for being back. Appreciate it. I have a few family of Rotary announcements. Bill Kale's wife, Susan, is having hip replacement surgery in the coming days. So please keep them and her surgeons in your thoughts and prayers in the next couple of days. I see on the rotograph that we have a birthday here. So let's sing happy birthday to John Mather. Happy birthday to you. Happy birthday to you. Happy birthday, dear John. Happy birthday to you. And and Lynn and Dave have a anniversary. Which one coming up, Lynn? 43 years old. 43. Well, congratulations, Lynn. Any other family of Rotary announcements for the greater good of the group? Yes, Maynard. Well, good. Thank you for visiting the Mount Pleasant Rotary Club, Maynard. I'm glad they didn't have any outstanding warrants on you. Not yet, Les says. That's right. A few club announcements. Again, district conference is April 1 through 3 this year at the Hotel Roanoke. You should have got a whole bunch of details in the email. If you haven't, please let me know and we'll make sure that you get those. Again, if you register to attend, your registration is covered by the club. So please let us know that so we can reimburse you. Next week, one of Wayne's presenters had to reschedule, but instead of rescheduling an entire meeting, we're going to meet here as in a fellowship social type of way. There'll be also several club announcements that we'll want to make next week. So please plan to attend that and to get to know your fellow Rotarians a little bit more. Yeah, important announcements coming that week. The board has decided to continue mask mandating until our next meeting, which is March 14th. So please continue to wear your masks when you are not eating. I will give you a heads up that we will probably amend that at the next board meeting. So we'll send out some further information on that. Also, please continue to record your service hours on the Google Sheet provided by Michael every week with the rotograph. Any other announcements for the greater good of the group? All right, I want to welcome Corey Davies up to announce our speaker today.
Good afternoon, everybody. It's a pleasure to be back. It's been a few months since I've been to a meeting in person, so it's good to see everybody. But I'm here and I have the pleasure to introduce my boss and the president of Sentara RMH, Doug Moyer. I know many of you have heard him before, but for those who haven't, I'll give a little bit of context to what brings him here. So Doug began his career as an athletic trainer in a sports medicine and physical therapy setting. He started out as the director of physical therapy and program development for Johns Hopkins Health System. That's also where he did his residency and fellowship, his administrative residency and fellowship. He then went on to join Community Health Systems, Virginia Hospital Network based in Petersburg. In 2014, he took on the CEO role at CHS Virginia Hospital Network and for CHS Southside Regional Medical Center, also in Petersburg. He then joined Sentara RMH in 2017. So he just passed his 5-year milestone with us, and I know he's excited to be here and give you guys an update on what's happening at the hospital. So I'll turn it over to you, Doug.
Well, thank you and good afternoon, everybody. Everybody hear me okay? Lower that. Well, I really appreciate the opportunity to share a few minutes with you today and talk a little bit about the hospital. Kind of as Corey mentioned, it's been a while since we've been out and about in the public setting. You know, COVID's really taken every minute of our day for the last 2 years. So as things are starting to transition a little bit, it feels good to start to resume a little bit more of a normal. Let's see if I can. Is that working? Next slide. All right, thank you. So probably the best place to start is to talk a little bit about COVID. You know, since 2020, we've really seen a number of pretty significant surges through the hospital. It's been well noted. Actually, Augusta and UVA, with the most recent trend, did a public campaign asking for public assistance and help. We were really in pretty much the same boat with our numbers, which are extremely high, but we're fortunate that 2022 seems to be a very good trend for us. The Thanksgiving in September, or Thanksgiving and Christmas exchanges of family and everyone being together tends to see the COVID numbers drive up. So we've really gotten past that. Today marks the first time in 2 years we've been in single digits in the hospital. So we're really, yeah, we're pretty excited about that. And really what that means is that when we were in our peak, which was really a large part of the last 2 years, because COVID numbers were so high throughout the facility, you know, we shut down a number of programs and reallocated staff. Largely our operating room staff was reallocated, as were a number of other folks throughout the building, including the administrative staff. We worked nights, we worked weekends, we did everything from run supplies to take out the trash to do whatever was needed on the floor. So we're starting to put all the units back to what they're more accustomed to doing, which makes it feel good for all the folks in the building. And the operating room schedule is really almost back to a full normal, which is a good feeling as well. So hopefully the trend will continue and we won't see a surge. Some of the projections still show that we could see a bubbling in July, interestingly, or certainly in September, October of next year. So we'll wait and see what comes. Next slide. So maybe I'll pivot for a moment and talk about the journey that Sentara RMH is on. And this is probably difficult for you to see. We're the orange bar, which I'm not sure I can discern the colors on that graph either, but I can tell you what it means. And what it means is that, you know, every hospital in the country, it's our job to try to improve quality and reduce costs. And the last time I spoke with you all, I know I talked quite a bit about that is still a mainstay strategy that we try to undertake each and every month when we undergo our strategic discussions. What the slide talks about is that over the 10-year relationship of why it's important to be part of a family, and Sentara is our family, 12 hospitals across the Commonwealth, there are some pretty unique strategies that Sentara undertakes that helps drive quality. And what that shows is that over the 10-year run, specific to mortality, complications, and 30-day readmission rate, Sentara RMH has gotten significantly stronger in all three buckets, as has all the other. That marks the Western hospitals that we are part of a group of within Sentara. Sentara was recognized as being one of the top 15 health systems in the country over this past year. It also marked for the first time that Sentara RMH was noted as a top 100 hospital nationally, and we were ranked 9th in the Commonwealth. So it just reflects the hard work that the staff undertake every day, the physicians that we have, they undertake every day. And those are the things that we focus on. It's trying to make care better. We've not done a good job as an industry in terms of curbing costs. But that's something that we're trying to get better at as well. And what that will likely be reflective of is a much larger outpatient presence. That means ambulatory surgery centers, freestanding imaging centers, taking care away from maybe the hospital setting and being in more of an outpatient setting where the costs are lower. And so the more that we can drive care that direction, probably the best example I can give is mentioned total knee or total hip that someone's getting ready to undergo. Maybe it was Bill Cale's spouse. But those are largely done same day outpatient, which is hard to even comprehend. I mean, typically that was a 2-day or 3-day, certainly an overnight, and now you're home for dinner. So again, it was a great example of how care is transitioning. Next slide. Much of the work that the hospital's undertaken over the last really 1.5 to 2 years amidst COVID has been to do some rebuilding of the medical staff. Much of it is primary care, which we've had a large deficit in primary care going back probably a decade here in the Valley. In 2019, I think, maybe 2018, I'll look at Jenny because Jenny holds me accountable to whether I'm accurate or not. We had, I believe, 7 retirements of independent primary care docs in the community. Likely they all graduated and came in and hung their shingles around the same time, enjoyed great careers here in the Valley. And it's, you know, as much as we didn't want them to retire, they're entitled. And so we had a large out-migration of primary care talent and not enough to really capture what was left. Primary care also is one of the most difficult recruitments nationally. You wouldn't think so, but it is very, very difficult to recruit primary care. And so with that, I think our total number was 9 between nurse practitioners, PAs, and physicians in complement, and they're spread around our different sites from East Rockingham to South Main to Timberville. So it feels good to have primary care back in the market. And then a number of specialists as well, from endocrinology to orthopedics and the like. So a lot of folks getting acclimated to our surroundings and joining us in the Valley. Next slide. And so with that comes some new programs. It's always good to be growing and developing. We try to watch very closely through community needs analysis, which we do a pretty robust analysis every 3 years, and we update it annually. And it really tries to direct us as to where do we put our resources, what does the community need. Much of it we just try to focus on what leaves the Valley that we can't provide locally, and how do we better provide services to take care of the folks that live here. And these are examples, whether it's the heart failure clinic, some new procedures, cardiac shockwave. It's kind of like a lithotripter to your heart, so to speak. If you know how they take care of kidney stones, it sounds terrible, but I think it's pretty effective. CardioMIMS, this marks our almost our 1-year anniversary for Da Vinci robotic surgery at the hospital, which has gone exceptionally well. And then expanding cardiology to the Women's Center, the Funkhauser Women's Center. So, and we've got several other things in the works in terms of how we continue to evolve and grow and develop. Next slide. So what are the challenges in front of us? Well, the same challenges that we've really had over the last 1.5 years. And COVID drove a lot of the change. This is not a local issue. This is not a regional. This is a national level issue. Critical care was hardest hit. ICU, PCU, emergency department staff. The exhaustion and the arduous days that are reflected by COVID, really took a toll. And folks said, either I'm going to retire early or I'm going to find a new career somewhere doing something else. and it takes time to replace that. And so supply and demand means everybody's trying to rob staffing from everybody else. And I think likely in our region, UVA was probably hardest hit. I know Augusta, Winchester, and RMH were all equally as hit, with critical care folks sliding out. Means that we work, and we've always worked closely with our schools to try to develop new pipelines, but you know, the number of students that we know coming out mathematically won't match our needs. So we've got to continue to be forward thinking and try to come up with new models, new ways to do the same things that we've always done. So we're looking at some new models within the hospital, largely driven around trying to spread our RN job duties out a little bit differently than we have in the past, reintroducing LPNs into the team concept in the workforce and what that looks like. So all that's happening quickly. The same has occurred with physicians. We've seen a lot of physicians either retire early or leave their careers as what they had originally intended and pursue other things that are largely non-clinical. So it means that when we recruit to backfill, if we can, it's a national recruit. And, you know, I think we found that our setting, we love recruiting people that have a tie to the Valley, that either grew up here or have family here or went to JMU. Some kind of a tie. We feel it's always the best fit for us. But that being said, it's a supply and demand equation, and this is a national search at this point in time for things like gastroenterology and urology and a number of other specialties where, you know, the number of hospitals seeking those candidates or those graduates far outweigh the number of graduates that we have. And so, again, telemedicine will take a new front and center approach for us. And I think we're fortunate in that, quite honestly, I think we've been more effective recruiting physician talent than most locations in the state, but we still don't have as much as we'd like to have. So it's an ongoing effort. I also made a note, kind of centers of care. You know, I think as we start to think through that, understanding that these shortages are going to be long lasting, then how do we provide care where it's less strenuous for the patient or the consumer? Meaning you're not having to drive miles and miles from one office to the next office to the next, but that maybe we group all of our physicians in a central location where when you come, you can see your cardiologist and your pulmonologist and your neurologist or whoever you're seeing. You can make the most efficient use of your time and your energies as a patient as well. Next slide. And so with that, you know, I think my closing comment would be that, you know, I think we're also trying to be better listeners to our community and better understand what our community wants and needs. We spent a lot of time in 2020 and 2021 kind of thinking through that and what does that look like. And so I think we're hopeful to be more front and present with community functions. And again, COVID's kept us in the house for a long period of time. I'm sure it's done that with a lot of industries, but we're looking forward to getting out and being front and center with you all more frequently. So with that, I'm happy to, if there's time, I'm happy to answer a few questions if you have them. Mm-hmm. Well, that's where we go to get our short term while we're waiting for the students to come out. And once you get the students, it often takes, you know, and it depends on what they're doing. It can take 3 to 6 months to orient them and get them ready for their job role. So yes, we use travelers. In certain states, there's been a lot of union activity. And so with that, the travelers have gone to states where there's strikes, where nurses are striking against the healthcare organizations. And so with that, many of our folks, even in the Commonwealth of Virginia, migrated to California, Texas, et cetera. They're settled. And so we're seeing them re-enter the workforce back in Virginia. So that's a a positive for us. But yes, travelers are part both on the physician side and the nursing side for how we address our short-term needs. Yeah. Not more than we've traditionally had. Yeah, if anything, I think, we've seen some of the emergency orders that were put in place by the governor over the last year that's really made it really easier for us to function. Much of it's around how we credential. When somebody comes in, when someone enters our domain, specifically on the physician side, they don't just enter. I mean, there's a lot of processes we go through to vet their background and their history and what they're coming with so that we know exactly. And then typically, even then they're proctored for a period of time. So none of that's changed, which is a good thing. Yep. Yep. So I'll repeat the question. So this question was around the new Velocity Urgent Care that's located on the corner of Stone Spring and 33. And it says Sentara on the door. So I suppose that means we're involved in some shape or form, right? So we are a joint venture partner with Velocity Care. We don't locally have any oversight into their daily operations or what they do, but we are distant cousins, so to speak. So we do watch closely what they're doing, and we are in constant communication with them, which I think is a real positive. I think one of the challenges in healthcare as a whole, right, is that we're on Epic, which is our electronic medical record, and we would love it if all the urgent cares in the area, we had a better way, and all the physicians' offices for that matter, we had a better way to share data, share information, share patient data back and forth. Makes it easier for us to, as patients go from site A to site B, for the physician just to look and see what's there. That is a very difficult thing to do. And then, quite honestly, medical records that are designed for the office setting, right, a traditional physician's office setting, really don't function well in an urgent care setting, which is more episodic. It's a different style of care, a different type of care. So short story being, they really have their own electronic medical record, and they should have. We've got to figure out how to get it to interface with ours. Same with MedExpress and the other urgent cares in the area, which, again, we love what they do. We're all partners in providing the care. We just got to get better at how we share the data. Concerned about?
Hello. You talked about how the COVID pandemic has had an impact on keeping employees, and some have retired early and some have chosen another career.
Right.
What has Sentara been doing, and what will you continue to do to retain the good employees that you have?
Yeah, great question. So, some of it's around money. We've given more increases in the last probably 18 months than I've ever seen in my entire healthcare career. So some of it's financially compensating folks for it. I think the other component is trying to find a way to provide some work-life balance, which we've not had much of over the last 2 years. If anything, we've had anything but. The number of overtime hours and extra hours that we've asked people to work intentionally over the last 2 years so that we could keep our nurse to patient ratios reasonable, which has been a very difficult thing. And that's, again, what you've heard Augusta and UVA talk a lot about in the public setting. So it's trying to find ways to balance that workload. And then, again, we're seeing the compensation levels for nurses at an all-time high. So out of the gate, that's part of what it is. And then, we've certainly brought travelers in, which our staff, it's a double-edged sword. They don't like seeing people that are making unbelievable incomes next to them as a traveler. That's what they get when they travel and they do that work. At the same time, they're being brought in to manage those ratios and provide an extra set of hands right next to them. And again, the travelers are a short-term fix, but still a very needed bolus of labor for us at a local level.
Doug, I know that there are some local healthcare providers that may have changed profession or location based on vaccine mandates.
Mm-hmm.
Do you
correct.
see if numbers stay low, that changing for Sentara requirements in the near future?
No, I think, we're probably, and I'm saying that just based on my best understanding of, we've required folks being vaccinated. That means the first 2 shots. The booster is not currently included in that. My assumption will be that at some point in the future, we will require that, although that mandate's not been announced yet. Masking is interesting because while the rest of the world will likely go back to not masking in our setting, we're likely going to mask for I would imagine, a pretty long period of time. We've even been asking the questions, well, does that even mean non-clinical areas like administration? And at this point, the answer is yes, we'll mask across the board. So when you enter our building, we'll continue to mask. I know that's not popular, but we've had so much COVID around us for such a long period of time. It's a natural reaction for us to be overprotective. What's interesting is we've seen over the last 2 years, as we measure folks that in our setting, our staff that have gotten COVID, they've not gotten it at work. They get it out in the community or wherever else they are. So we're doing the right things in the building. We know that, and that's reaffirming that, if you use the right PPE and wash your hands and mask and gown and glove, and if you watch someone don and doff their PPE for a COVID patient, it's incredible. The amount of extra levels they go to protect themselves. The other part that I'll share is that even though we've had a significant amount of turnover in our staff over the last couple of years, I think we were still at around 13%, which is pretty high for us. We usually average around 11. It's probably the lowest in the state, or one of the lowest in the states, the lowest in Sentara. So we have 12 hospitals. No one was even close to 13%. So while it feels like a lot to us, and it is, we're thankful that we didn't have more of a transition as we've seen in other hospitals across the Commonwealth.
With the PPE and the precautions you've been taking over the last 2 years, have you seen some maybe not unexpected, but additional benefits to in-hospital infection? Because there was, my father developed he had knee surgery and 20 years ago, but that was a high risk at the time. I can't remember the right word for it, but whatever it was. But
yeah, great question. I think so. We look at infections from surgical infections to bloodline infections to catheter-related infections. We look at them every day. Sometimes it seems like we look at them hour to hour. So that's how we're judged and how we're gauged. And those slides that I showed you in the beginning that showed how much better we've gotten, and the fact that we were recognized as the top 109th in the Commonwealth means we've really improved in those areas. And yet, to answer your question, have we gotten better on that front? Nothing that correlates that all the extra PPE and the donning and doffing and all the care that we take. I think part of that is we've introduced so many new people to our setting, right? And so if we had all the folks that we had before, we probably would have seen maybe more of a drop. I think we've held serve and we've probably seen it stay pretty flat or pretty constant. But as your staffing levels get stressed, it would reason that you probably see some of that go up. But we watch that very, very closely. So hopefully there's some lessons learned from that we can figure out maybe a better way to work going forward.
Mr. Moyers, I'm a retired orthopedic surgeon. I was on the staff at RMH for 20 plus years. I've been interested to see the turnover of orthopedic surgeons since I've been retired 10 years. Can you speak to that?
Yeah, so So the orthopedic group that was part of Sentara Medical Group, so they went through a compensation redesign, and with that was hugely unfortunate, but we saw the departure of 6 of our orthopedic surgeons. One returned, Sophia Leung, and then we've recruited around her, and we've got the full complement back in place, spine and joint and 2 sports medicine surgeons. And then we're probably going to recruit for trauma/general going forward. So that'll round us out. But yeah, we hated to see that level of turnover at a local level. You know, I think change is difficult no matter how you slice it. So, but I think once it's in motion, then, you know, it's our job at a local level to drive through it and recruit the best talent we can to this community. And we are pretty excited about the new folks that we have here with us today. So they're top tier physicians, and I think they'll be a great part of our community going forward. Yeah. Say thank you, and we need you, John. We need you.
So it seems like there's been a lot of talking about this turnover among doctors. And I remember when I was younger, I had the same primary care physician almost my entire youth, from being a child all the way up to when I finally left home.
Yeah.
In the last 10 years, I've probably had 4 primary care physicians here. So there's clearly something going on, not only locally, but nationally and regionally, like you've talked about. Can you speak a little bit just from a macro perspective of what you see as the issue here that's creating this transience, and whether we need to do something differently about how we start our doctors through their course of study all the way through the process of getting them into working in hospitals?
Yeah, so I don't know the answer to your question's a great question. And it's hard for me because I've only been here 5 years, so I don't go back as far as the context you're providing. But, you know, I think in the last round, we lost 3 primary care and 2 came back. So we ended up losing 1, which was unfortunate, but they still stayed in the community, which is a positive. And then we've recruited so many folks around them. You know, retirement's retirement. And I think the largest outmigration of primary care during my time frame here is still associated with retirement. And there's nothing we can do to prevent that other than pre-plan and do our best. And we recruited with a lot of those folks, trying so hard to get folks to come and join them in their practices. But what we see, probably the change that's occurred for physicians today versus maybe physicians of yesterday, is the way they want to practice. They tend to want to be part of larger groups. Call is a much more discussed topic when we recruit than it ever was in my past going back. And that's probably more associated with the specialists. Call is part of what you do as a physician, but I think they enter understanding they want a less amount of call than what we've been able to traditionally provide. Our challenge comes that we're a 230 bed hospital, so we're not large. We're also not small. We're kind of in that mid-sized category. And so the size of those practices are only going to be but so big based on the community we serve. So, you know, it's a numbers game. I think for urology, that was a big part of our challenge over years was call requirement. You know, they didn't want to be 1 in 3. They want to be 1 in 6 or 1 in 7. And it's hard for us to provide that. So that's the challenge we have on the primary care front. I would say the other side to that is that maybe the younger mindset, I hate to say this because I'm getting old enough probably now where I can view this differently, but I think they look at everything like it's a 3-year play. Let's evaluate it and see whether I like it. And I may go off and, you know, Major League Baseball free agency, right? So, and that's different. I mean, that's different than the guys that came and hung a shingle and stayed for 30 years or longer, right? In some of these instances, folks in this valley have practiced here a really long time, which speaks volumes about if we find the right fit, we'll get a physician that'll stay for a long, long time. But it's interesting to your point, even in the medical staff meetings that we've had, they talk about it in the medical staff meetings at the hospital that the mindset's different. The younger docs' mindsets are different. And in the olden days, a lot of those physicians loved to be community docs. Now they want hospitalist work, which it's a known, right? It's a known amount of time with no call. That's what they want. They don't want to be on call. They don't want to carry a pager. They want to come in, do their shift and have quality of life. And that's what we see. We're seeing the same thing to that point occur with surgeons. So the surgeons are saying, well, what if we had a surgicalist program and then we don't have to take call? And the same thing with, a lot of our other specialties, we're going that direction. So the hospital may look different over the next 5 to 8 years. Laborious, maybe at some point in time in the future, not now, probably, but because there's that rumor going around the hospital on a daily basis. But you see a lot of laborious programs nationally. OBs have an unbelievable call schedule on their lives. It's very difficult for them. So I totally get it. I understand it. And that's the kind of thing that we're going to see migrate. And that goes back to the earlier comment I made that inpatient becomes higher acuity, sicker patients. A lot of that other stuff goes to the outpatient setting where it's lower cost of care. And our physicians are adapting their lives and their practices to accommodate that as well. Really good questions.
Just as a follow-on for that, how does that style of practice impact the patient concept of what they're receiving?
Yeah, so we're a little late to the game in the Valley. You've seen this transition about a decade ago in most other larger markets. Our folks in the Valley are still accustomed to, and we went through it with the hospitalists years ago. So if you went to see your primary care doctor and you were admitted to the hospital, that patient wants to see their community doctor around on them in the hospital. That doesn't happen anymore. And our patients still don't like that. Laborists, so you see your OB in the office and then it's time to deliver your baby. Well, typically if it's after hours, you get who's on call anyway, but it could be at least someone in their group. Going forward, that would look totally different. You get the hospitalist OB, whoever's working that day, and that's what you have. Same for surgicalists. So if we go with a surgicalist program, we would likely have 3 general surgeons that would take all kinds of surgical work. And the surgeon that you see in the community probably is not the person that's going to come in and do the work in the hospital. They're going to do more of the outpatient work. So our community is not accustomed to that style of medicine. And yet, if you go to Richmond or DC or, it tends to be larger markets, but in the larger markets, that's commonplace and has been for a decade. And now you're seeing it cascade outward. And so smaller communities like ours are starting to catch up. And so what we face is the doctors in our community say either we've got to get to that point so they can take less call, or they're going to leave and move to one of those communities where they can take less call and they don't have the call burden. So it speeds up our pace of play as a hospital to try to keep up with that. Yeah, great questions. Thank you, everybody.
Thank you very much, Doug, for that very informative presentation out of Sentara RMH. We appreciate you taking the time to be here. Jenny, Corey, likewise, thank you very much for being here. Just a reminder, next week we'll have a social followed by a important club meeting. So please plan on being here next week for that. Otherwise, we are adjourned. Have a great rest of your week.